Hello, this is Myron Churchman. I am the chief of the Lymphoma Myeloma Service and a professor of oncology, as well as the head of the Lymphoma Translational Research Laboratory in the Department of Medicine and Immunology at Roswell Park Cancer Institute in Buffalo, New York. I would like to discuss today an overview of mantle cell lymphoma, including also two cases for us to overview and to discuss, and to basically ask questions about therapeutic approach and the optimal choices for treatment for patients with specific characteristics that are going to require therapy. At this point, before we go to the cases, I'd like to just briefly review some background with respect to mantle cell lymphoma. We understand that mantle cell lymphoma is an aggressive subtype of B-cell lymphomas. It makes up about 6% of newly diagnosed cases of lymphoma in the U.S. and between 3 and 10% worldwide. The incidence increases with age, and typically the most common subtype is classical, about 87% of the cases, but also more aggressive subtypes, including pleomorphic as well as blastoid, are also seen. Blastoid being very resistant to standard therapies. In addition, we understand that the histology is quite specific for mantle cell lymphoma. It includes B-cell markers such as CD20 and CD19, but also T-cell marker CD5 on these B cells, as well as cyclin D1 overexpression. And it's also characteristic to have 1114 chromosome translocation. The median overall survival of these patients is about 6 years, but improving over the last few years with the addition of other novel agents for these patients, and also for prognostic information, primarily for overall survival, not progression-free survival. As in other subtypes of lymphoma, there is a mantle cell international prognostic index called a MIPI, which can be utilized to evaluate the patient's prognosis. In addition to this, the clinical features of mantle cell lymphoma are interesting as compared to other subtypes of lymphoma. It is much more common in men, at about a 4-to-1 ratio compared to women. The median age of mantle cell lymphoma patients is around 70 years of age, and the vast majority of patients do not present with early disease, but with advanced stage disease. 30% of patients will present with a leukemic phase. And then what should be noted is not just bone marrow involvement is common, but also that GI involvement actually may be underestimated, and that patients could have GI involvement and be asymptomatic. An elevated LDH, which is a poor prognostic factor seen about a quarter of the patients, and that beta-2 microglobulin can be elevated in a number of significant or majority of patients as well. Of interest, around 20% of patients can have an indolent course, and in those patients, watch and wait may be a reasonable initial approach, but the vast majority of these patients are going to be required to go on therapy, typically with around 6 months of time. Some factors which we need to consider when choosing a treatment for our patients with mantle cell lymphoma is similar to what we need for any cancer patient, is their performance status, their comorbidities, their age, what subtype of lymphoma they have, how quickly is it growing, what is the level of bone marrow reserve in our patients, if they can handle aggressive therapy or not. Also, with respect to if we're going to be choosing second-line therapy, what agents do we use in their first-line therapy, and how long did the first-line therapy last before the patient progressed, giving us an indication of perhaps how aggressive and or depending on the therapy, how drug-resistant are the patient. A brief treatment approach in mantle cell lymphoma, just as a brief overview, is that once we first confirm the diagnosis, typically with the 1114 translocation or cyclin D1 overexpression of these tumor cells, we actually can risk stratify the patients by age and comorbidities. In a young, healthy patient, in which we will call patients under the age of 60, a very aggressive or dose-intensified type of therapy, in plus or minus an autologous stem cell transplant for consolidation, is typically considered. In the elderly patient over the age of 60, conventional type of combination immunochemotherapy is typically utilized, and in those patients that are elderly with significant comorbidities or poor performance status, basically our goal is not necessarily to achieve complete remission or curative approach, is that instead we want to actually improve quality of life and limit toxicities and actually prolong life in these patients. So with that, why don't we start with actually our cases, and let's start with case number 1. So let's meet Miss J. She's a 54-year-old woman with a past medical history of type 2 diabetes and hypertension, both controlled on medications, and also past surgical history of cholecystectomy when she was 42 years of age. So her social history, she's teaching high school. She's a high school English teacher. She's been married for 20 years, has 2 healthy daughters, and she denies any smoking, alcohol use, or recreational drug use. And her family history is actually negative for cancer. She has a 3-month history of abdominal bloating, early satiety, decreased appetite, and easy fatigability. She has palpable increasing bilateral neck and axillary adenopathy, which she made a note of. And for that, she went to see her doctor. Her primary care physician noted that she had adenopathy, palpable adenopathy, as was noted by the patient. They measure around 2 to 3 centimeter in size, and also the physician appreciated she had an enlarged spleen, approximately 7 centimeters below the left costal margin, and then she was referred to a local oncologist. Upon workup, the CT scan demonstrated that she had diffuse lymphadenopathy above and below the diaphragm, maximum being 4 centimeters. Excisional lymph node biopsy confirmed the diagnosis of mantle cell lymphoma of usual phenotype. Of note, the Ki-67 can give us an idea of how aggressive lymphoma is. Being 60% plus is high, but it's actually different. If they're in the, say, the 10 to 20%, they're quite indolent. Being 60%, I would say, is approximately average. Those patients in 90% or above would be considered quite aggressive. So the bone marrow studies were performed, demonstrated involvement of the marrow, and her routine MUGA scan demonstrated that she had a normal left ventricular ejection fraction. A PET scan was done that showed that the areas of adenopathy they were FDG avid, and laboratory studies showed a mild anemia, an LDH that was above normal limits, and an elevated beta-2 microglobulin. She's therefore diagnosed with stage 4A mantle cell lymphoma. So at this time, what do you recommend as upfront therapy for Ms. J? A, R-CHOP, followed by rituximab maintenance. B, VR-CAP, bortezomib, rituximab, with cyclophosphamide, doxorubicin, and prednisone. C, bendamustine and rituximab. D, the hyper-CVAD regimen, which alternates hyper-CVAD with high-dose methotrexate and Ara-C, cytarabine. E, the Nordic regimen, which is actually a very aggressive regimen, was called actually R with a maxi-CHOP alternating with rituximab with high-dose cytarabine, or F, alternating R-CHOP with R-BHAP, decadron, high-dose cytarabine, and prednisone. At this time, please take a moment to choose your answer. So, assuming that Ms. J achieves a complete response, or say a very good partial remission to your induction therapy that you chose, would you consider consolidating this patient in first complete remission with an autologous stem transplantation? A, yes, or B, no. Wait until second complete remission. Please choose your answers at this time. Okay, well, let's go over the answers and some key points with respect to the care of Ms. J. So specifically, we're dealing with a younger patient with no significant comorbidities. She does have symptomatic disease which requires our intervention for treatment. So typically, an aggressive induction therapy for this type of patient would be considered standard of care. So what I'm going to say is that there wasn't just one correct answer, that acceptable answers for this patient's initial induction therapy would include either D, the hyper-CVAD regimen, E, the Nordic regimen, or F, alternating R-CHOP with R-DAP. So It should be noted that improvement in outcomes was most notable in the last decade or so in patients who received, or at which point treatments introduced high-dose cytarabine, as well as in patients who received Rituximab in their induction regimens. The second part of the question is whether or not would we go to an autologous stem cell transplant. The answer would be a yes, that we would consolidate these type of younger patients today with autologous stem cell transplantation in first complete remission. We would not wait until second or subsequent CRs to transplant these patients at this time, since it has always been clear that in general, a patient that gets transplanted earlier in their course of the disease has a much better chance of longer remission durations and potentially curative type of outcomes than a patient to get transplanted later in their course of disease. So in follow-up, Ms. J achieves a complete remission for 4 years post her stem cell transplant, and unfortunately recurrent adenopathy is noted. Her workup is positive for recurrent mantle cell lymphoma, and second-line treatment options need to be considered, which will be discussed later in our presentation. At this point, let's move on to a second patient. Let's meet Mr. A. He is an 80-year-old gentleman with a past medical history significant for coronary artery disease. He had an MI at age 68, had stents placed, and currently his cardiac function is actually very stable on the medications and follow-up with his cardiologist. He also has a history of congestive heart failure, and his left ventricular ejection fraction runs about 40%, normal being 50% or greater. And he has some mild chronic renal insufficiency. He had a right hip replacement 4 years ago, as well as having some complications with wet macular degeneration, for which he receives anti-VEGF injections into his eye with stabilization, but some decreased in his visual acuity. His social history is that he's a retired post office worker. He's been widower for 8 years. He resides in an assisted living residence. He has 3 adult children that live not close, out of town. The closest one is a 1-hour drive away. Where ethanol use, he was a smoker, 40-pack year smoking history. He quit those 15 years ago and does not have any residual emphysema or problems. So his clinical course is that he's been feeling out of sorts and a little bit of weakness for the last 2 or 3 months. And he noticed that he had developed suddenly bright red blood per rectum, at which point he had a fair amount of bleeding, and he was called the ambulance, and he was admitted to the local hospital with bright red blood per rectum, GI bleeding, and anemia. His hemoglobin was down to the 8.5 range, and upon review of systems, he had a decreased appetite. He had lost about 20 pounds in the last 3 months because he's had problems with his appetite. And on examination, abdominal exam was relatively unremarkable. He had some splenomegaly that was appreciated, but in addition to that, there was just some non-bulky small nodes appreciated that were non-tender, as normally as we would expect in patients with lymphoma. And with respect to the workup they did while he was hospitalized, again, he was anemic, 8 to 8.5. He received blood transfusions. It was interesting that they noted that he had leukocytosis, his white count being elevated 35 with a lymphocytosis, 80% of these cells being lymphocytes. And he had an elevated LDH N by the 2 microglobulin. He had an upper endoscopy, which was unremarkable. But a colonoscopy, very interesting, showed that he had lymphomatous polyposis. He had innumerable numbers of polyps within the large intestine, and these were biopsied, and after the biopsy demonstrated that it was consistent with mantle cell lymphoma. CT scan showed non-bulky nodes about the size of 1.5 to 2 centimeter nodes in the axilla mediastinum, as well as in below the diaphragm as well, including pelvic nodes. Actually, a excisional, one of the lymph nodes was biopsied and also confirmed what we found from the polyps. It demonstrated classic mantle cell lymphoma and was, again, comparable to the polyps. Q67 was around 30%. The flow cytometry of peripheral blood, noting that he had circulating lymphocytosis, was consistent with leukemic phase of mantle cell lymphoma, and he was diagnosed with stage 4B mantle cell lymphoma. These symptoms being greater than 10% weight loss in less than 6 months. So what do you recommend as initial treatment for Mr. A? A, watch and wait. B, R-CHOP followed by Rituximab maintenance. C, the VR-CAP regimen, where we're replacing vincristine with respect to bortezomib. D, bendamustine Rituxan. E, an aggressive induction therapy approach, as mentioned here, the hypercvad, Nordic, or R-CHOP alternating with RDAP. F, Ibrutinib. G, lenalidomide plus rituximab. Or H, a purine analog, for example, fludarabine-based therapy with rituximab or cladribine plus rituximab combination therapy. So with respect to that, please, with those options, please choose what you feel is the best treatment for him at this time. Assuming that Mr. A achieves a complete remission or a very good response to his upfront therapy, would you plan to give this patient maintenance rituximab for 2 years? A, yes. B, no. Or C, maybe. In parentheses, depends on the induction therapy used. Please answer the question at this time. Well, let's review this case and what answers I feel are actually more optimal for this patient. First, we should note that Mr. A is 80 years of age. He has acute symptoms of a GI bleed. They're symptomatic. But also we have to keep in mind he also had B symptoms with that significant weight loss and the significant medical comorbidities, especially the cardiac issues, the coronary artery disease and cardiomyopathy, which is controlled, who also is a widower and lives alone. I believe that the correct answer and what we should be looking at is a non-aggressive approach. So acceptable answers here would be either D, bendamustine Rituxan, H, purine analog plus rituximab, keeping in mind that that is not maybe utilized. It's still very active. There is data supporting it that in the old days, we'll say, when I say old days in the past, we did use a lot of purine analogs. I think that most people would choose actually from recent data the bendamustine Rituxan combination, but we should keep in mind in elderly patients that it's still a very reasonable option to look at a purine analog combination with Rituxan therapy. I was going to say, and those people who answered F, Ibrutinib, I'm sure it would have clinical anti-tumor activity, but it's not FDA approved as a first-line therapy. And those of us, and those of you in the group saying that maybe lenalidomide and rituximab, there is data from a recent study that was done at Cornell that showed promising data on upfront lenalidomide and rituximab. However, we should note that it's not FDA approved as an induction therapy. It's approved in patients with relapsed refractory mantle cell lymphoma. We just wanted to make sure that the answers that I would feel that are not acceptable would be a watch and wait approach. Patient has acute bleeding and symptoms, and that the next choice is B and C, R-CHOP or VR-CAP. I would like to avoid anthracyclines in this patient because of his cardiac history, and that also E, the aggressive induction therapy. This patient would never tolerate an aggressive approach at his age, as well as that we were going to show you some data that even with our hypercvad, and those patients over the age of 65 have a much worse, we'll say, overall progression-free survival as compared to younger patients. So the second part of the question, maintenance Rituxan for 2 years after induction, I actually would say C, maybe. And the reason I say this, when you utilize a non-aggressive induction or a second-line therapeutic approach that's less toxic in these patients, an attempt to achieve, a good PR or at least good response, if we want to actually have continued disease control, an attempt to prolong the patient's life and have him continue to live independently, there is data from the German mantle cell lymphoma study group that patients who had received R-CHOP actually received and it wasn't 2 years. It was to receive Rituxan maintenance, one dose every 2 months indefinitely. However, The current standard would be one dose every 2 months for 2 years. Now, I think that we can extrapolate that in this elderly patient that it would not be unreasonable that depending on the regimen and also his overall response, that this patient, at least we should consider giving him Rituximab maintenance therapy because of his age and his other comorbidities. Okay, after we've just reviewed these two cases and our choices with respect to what would be, say, more optimal for therapy for a younger, healthy patient and an elderly patient with comorbidities, two extremes. What I'd like to just go over now is a little bit more information about the data that supports our choices and some additional information with respect to mantle cell lymphoma. What I'd like to mention is that being part of the NCCN guidelines in lymphoma, I feel that that's a very good resource with respect to, which can be seen online, that with respect to various induction therapy, which is divided into an aggressive therapeutic approach with a number of the regimens, in addition to some other regimens that we just discussed, as well as a less aggressive approach in those patients that we feel, based on their approach to us, whether they're elderly or younger, that might not tolerate an aggressive approach, a less aggressive therapy, including the bendamustine Rituxan approach, VR-CAP, and then CHOP Rituxan. We also will be discussing first-line consolidation in younger patients with respect to consolidating with autologous stem cell transplant. And not so much with respect to today's program, just to note that second-line therapy could include things such as bendamustine Rituxan, remembering that Ibrutinib is FDA approved for second-line or further therapy, as well as now in the VR-CAP and upfront therapy, and also the use of Purian analog combinations. And also we should just consider that radiation therapy can be palliative to decrease patients that have symptomatic disease, that these tumors are radiation sensitive. And in the small number of patients that have very refractory disease that are younger, we should still also consider the possibility of an allogeneic stem cell transplant patients. So let's review some of the regimens and some updated information. Rituxan and hyper-CVAD, alternating with high-dose rituximab, methotrexate, and cytarabine, and untreated mantle cell lymphoma, was spearheaded by Romaguera et al. From MD Anderson. It was interesting, an update a few years ago showed that at 7 years, a little over half of the patients had failure-free survival, and that almost 70% of the patients were still alive. And important prognostic pretreatment variables for this regimen, and it can differ depending on specific treatment we give, included the IPI, the age, beta-2 microglobulin, and LDH. It should be noted there was no pure plateau in the curves, saying that we still have other additional treatments and approaches that need for us to improve outcomes. However, in a younger, healthy patient, Rituxan hyper-CVAD regimen is typically used. It should be noted that in the use of it by MD Anderson does not include consolidation with autologous stem cell transplant with respect to their outcomes. The one slide that I think is very important to look at is that failure-free survival according to age. In patients that are 65 years or less, they have a little over 50% of those patients at 7 years are still remain failure-free. But if we look at patients over the age of 65, it is quite dramatic that those patients actually have around, say, a 2-year median or 2 to 3 year median of failure-free survival. So it could be related to either the biology of the tumor or that these patients need a little bit decreased dosing of cytarabine, which actually might explain why they don't do as well. So in my patients over the age of even 60 to 65, I do not utilize the hyper-CVAD regimen in those individuals. I feel that there is no clear benefit compared to, say, less aggressive approaches for those patients. Initial data that supported patients to have stem cell transplant was actually done by Driving et al. And that was in patients that in the European Mantle Cell Lymphoma Network got 6 cycles of CHOP-like therapy. And if they got a PR/CR, they ever looked at doing a transplant versus just consolidating the patient with 2 more cycles of CHOP and then using interferon maintenance. And from basically their outcomes, there was a dramatic improvement that was very statistically significant in those patients that got consolidated with an aggressive approach, an autologous stem cell transplant versus just interferon maintenance. So that actually built the bridge where we felt that consolidation with transplant is definitely necessary. In addition to that, there are a number of publications that demonstrated that an intensive chemo plus stem cell transplant in mantle cell was very important with respect to the Rituxan era, and with Geisler et al. Demonstrated in 160 patients with untreated mantle cell that giving this maxi-CHOP, Rituxan maxi-CHOP followed by Rituxan high-dose cytarabine for 6 cycles, basically alternating our maxi-CHOP with high-dose Ara-C, followed by basically high-dose chemotherapy and stem cell transplant, give excellent outcome with respect to 6-year duration of response, event-free survival, and overall survival between the 60 to 70%. So the results from this Nordic lymphoma group was that there definitely was an advantage when they actually introduced cytarabine and rituximab into their into the induction therapy. Variations on the theme I'll call was also other publications looking at, for example, using CHOP. For example, 2 cycles of CHOP, 1 cycle of Rituxan CHOP, and followed by Rituxan with DAP for 3 cycles, and then autologous transplant by Delarue, finding that the 5-year overall survival was 75%. And the previous study, which just simply was similar without rituximab, their event-free survival was only 51 months compared to event-free survival with this combination with the addition of rituximab was 83 months, dramatically different. This also helped confirm that the addition of Rituxan to cytarabine was not only safe and effective, but also dramatically improved outcomes. There was also a randomized trial by Hermine et al., published in 2010, looking at the mantle cell lymphoma, a younger trial of the European Mantle Cell Lymphoma Network, almost 500 patients, where they compared R-CHOP times 6 versus R-CHOP times 3, alternating with R-DAP times 3, followed by a stem cell transplant. And as would be expected, dramatic differences between those patients just receiving R-CHOP times 6 compared to those patients that had the introduction of R-DAP with autologous stem cell transplant. With respect to outcomes, not only the overall response rates were similar, but the time to treatment failure as well as the duration of response were dramatically improved with respect to those patients getting more aggressive therapy. So again, let's rehash upfront therapy in the younger stem cell transplant eligible patients. Standard chemotherapy alone can give you a good response rate, but it's not durable. Novel targeted agents are now being introduced into clinical trials, but it's a work in progress. We cannot utilize that, I don't think, at this point off of a clinical trial. And autologous stem cell transplant of first CR gives us the best results. And the data, again, clearly demonstrates take-home point, clear improvement in outcomes when you incorporate Rituxan with Ara-C or cytarabine in our induction therapy. So the conclusion would be that in younger patients, currently high-dose cytarabine-containing induction regimens, including rituximab, followed sequentially by either high-dose therapy with autologous stem cell transplant, results in the longest duration of remission for these younger patients. There's some data that actually will now continue that with bendamustine and Rituxan versus R-CHOP was included in the German STEEL trial that actually looked at various subtypes of lymphoma, included elderly mantle cell lymphoma patients. And they got randomized between bendamustine Rituxan versus R-CHOP. And this has been presented in the past and it's been published. And what it demonstrated that although the overall response rates were similar in these patients with mantle cell lymphoma, there was clearly an advantage in progression-free survival with the bendamustine Rituxan with respect to the about 3 years median progression-free survival compared to less than 2 years with R-CHOP. Even though overall survival of these patients can still be salvaged, it was just clear that in the elderly mantle cell lymphoma patient population, the bendamustine Rituxan combination was not inferior to those same patients receiving Rituxan plus CHOP therapy. Next, I think it's a very important trial was in the European mantle cell lymphoma in the elderly. It was published in the New England Journal in 2012. And newly diagnosed patients over the age of 60, they had good performance status at stage 2 to 4 disease. 560 patients were randomized between R-CHOP for 8 cycles versus the FCR regimen, fludarabine, cyclophosphamide, rituximab for 6 cycles. Achieving a PR or greater, the patients were either then randomized to alpha interferon maintenance or to Rituxan maintenance. And I mentioned it earlier when we discussed the cases. What was clear was that the R-CHOP was superior to FCR. Part of that reason was that these patients actually had more in the way of cytopenias and infectious complications with the FCR compared to the R-CHOP. And what was important here was that the maintenance for rituximab improved progression-free survival and overall survival compared with interferon in the patients treated in the R-CHOP arm. It should be noted that similar benefit was not seen in a group of patients treated with FCR. And when I actually discussed this with the actual authors, I think it was true that a lot of the patients had progressed, and there was not many patients who actually were able to go on, for example, to be randomized to the Rituxan maintenance after FCR, since the initial induction was not as good. Therefore, it is possible to extrapolate that perhaps other regimens still could benefit from the, say, 2-year Rituxan maintenance. But FCR, I believe it was because they didn't have a very good response compared to R-CHOP. And this protocol is why we saw that the R-CHOP arm did better. I should just briefly mention a lot of novel agents are very exciting that we're being studied right now, mantle cell lymphoma, and I would say including novel in parentheses, because bortezomib, we're looking at bortezomib, we know it's FDA approved. It works in about a third of the patients in relapsed refractory mantle cell lymphoma, and this could give us some activity. I think that we should keep in mind that the various combinations are still being studied, and we'll have to see additional trials where we can look at combinations. Now, lenalidomide is a single agent, also FDA approved in the relapsed refractory mantle cell, as is Ibrutinib. So keeping in mind those are 3 FDA approved agents in the relapsed refractory setting. I've mentioned briefly that also other agents not as well studied but have activity include idelalisib, IP145, temsirolimus, everolimus, HDAC inhibitors, and a very small number of patients exciting BCL2 inhibitor ABT199 has activity. Let's just discuss briefly lenalidomide in the patients who had prior bortezomib. In the relapsed refractory mantle cell lymphoma patients receiving the lenalidomide in the Emerge trial sponsored by Celgene showed that there was activity. About 30% of patients had an objective response, including about 8% CRs, and the median duration response being over a year, 16.6 months. This was a very heavily pretreated mantle cell lymphoma population. It showed that the safety profile was manageable, and that, like a lot of the novel agents, we saw a rapid response. If you don't see a time to response within 2 months, it's unlikely that these novel treatments actually will be active, and patients should be moved to another regimen. However, it does show that in some patients they had durable remissions. FDA approved actually lenalidomide as a single agent in this population in June 2013. Ibrutinib, very exciting, oral therapy, got breakthrough treatment status at FDA in early 2013. Michael Wong and his colleagues published results in a large international phase 2 trial in the New England Journal of Medicine in 2013, and a very dramatic and exciting objective response rate of 68%, including 20% CRs, and a median follow-up of about 15 months. Disease-free survival was, they saw 18 months, and the median progression-free being around 14 months, with the median overall survival not being reached, but estimated to be 60% at 18 months. It should be noted that there was no difference whether the patients were bortezomib naive or bortezomib prior exposure to bortezomib, and that as patients continued to be treated, they actually had an improvement between the presentation from ASH 2011-2012. Objective response rates didn't change dramatically, went from 69 to 75%. But of curiosity and actually very interesting was the complete response rate went from 16% and it doubled, went up to 35%. So in addition to that, we feel that ibrutinib is very important. It's not clear as to how long to continue. Actually, a number of patients right now is continued until patients develop progressive disease or intolerance to the drug. I think in the future we're going to see the combination therapies are going to maybe give us a shorter period of therapy. In particular, Dr. Wong also presented at ASH 2014 the combination of, for example, Ibrutinib and Rituximab in relapsed mantle cell lymphoma, so now adding Rituximab. And I think what was important here, it showed about a 90% objective response rate and actually a 40% complete remission rate, and the median follow-up was 11 months. And I think what's important is that potentially we're going to have to look at biomarkers to give us a population where we might get better response. In other words, where we can predict responsiveness. And what was interesting in this presentation at ASH was in patients who had a Ki-67, a proliferation index, that was greater than or equal to 50% of the mantle cell lymphoma, they only had a 50% objective response rate and 8% CRs. Whereas if they had a Ki-67 less than 50%, the patients of proliferation index being, again, less than 50%, there was a 100% response rate, and more than half of those patients, 56%, achieved a complete remission. I think it's very important to note that when we keep in mind selecting treatments for our patients. And I've mentioned earlier, frontline rituximab plus lenalidomide was done by Ruan, and it was actually presented at ASH 24, an update of this. This was a phase 2 multi-center study of basically what we call R-squared, as a chemo-free initial treatment in previously untreated patients. These patients actually had to have measurable disease, low to intermediate risk or high risk if they're ineligible for chemotherapy, and adequate organ function. And what was interesting here is that when patients went on this regimen, the objective response rate in evaluable patients was 90% with a 58% complete remission rate. The median time to achieve a PR was 3 months, and 11 months is the median time to get to a CR, and a 2-year progression-free survival of 85%. It also should be noted that 2 patients are actually discontinued early because of a tumor flare that didn't have progression of disease. And this should be kept in mind that these novel agents will have sometimes unique toxicities. And those patients who were taken off with tumor flare, we know that in CLL, the tumor flare could actually indicate that those patients most patients with tumor flare actually do have a subsequent response to therapy. But because of the study that was done at the time it was done, it was thought that those patients might not tolerate therapy well, and they were taken off trial. But also here, the Ki-67 or the MIPI score did not correlate with response. Again, different treatments, different objectives with respect to prognostic factors. So in addition, let me just finish here with some open questions and some conclusions based here. Basically, we know that in these patients that have mantle cell lymphoma, staging includes what we do for all lymphoma patients. I feel that's important, most importantly, that we rule out that they don't have a blastoid. Pleomorphic also is aggressive, but not as bad as blastoid. We have blastoid, histology. The only data I know is an aggressive approach. Hyper-CVAD, at the time that was last analyzed, showed that even though the curves showed that outcomes were a little bit worse with respect to those with blastoid, they were not statistically significantly different. So they didn't have statistical difference with respect to outcomes. But again, remembering that not all patients can tolerate, rituximab hyper-CVAD. There's been a question, should we scope these patients with respect to upper endoscopy and colonoscopy? And I think that varies depending on institutions. I think definitely if the patient has any evidence of significant anemia or, positive GI bleeding, I think that a lot of places, including ourselves, in younger patients that we're planning to take on to autologous stem cell transplant, if we don't do an initial workup and part of our initial workup, that after we complete therapy prior to transplant, they do have evaluation for any evidence of GI involvement. how to recognize good versus poor risk. I mean, I joke around. I say, when we see our patients in clinic, we know a good versus a bad risk, but we should be utilizing things such as the MIPI, the Mantle cell IPI, which can be found online, and actually a number of places can actually calculate by putting in the numbers. It's a very complex, basically equation, but it does give us information with respect to overall survival in our patients. And I also think that basically the Ki-67, as we've seen, as I just mentioned, can also be very significant. And then those patients with very high Ki-67s typically have very aggressive clinical presentations. And those with very low Ki-67s are the ones in particular that have a more indolent course typically, and those are the ones that we can watch and wait before initiating therapy and without giving any harm to that patient. What is the optimal first-line treatment for younger fit patients versus older unfit? We discussed that already from our case studies with the general idea: aggressive approach followed by autologous stem cell transplant, a first CR for our younger patients, and in the elderly patients, less aggressive approach, maybe with the 2-year maintenance rituximab, and other ideas are being tested now with respect to improving outcomes with perhaps the use of some of these novel targeted therapies. I think of interest is the CNS prophylaxis mandatory. I've reviewed the literature on this, and it's interesting that not many of our patients, we would expect more in patients with aggressive lymphoma with marrow and GI involvement, would have CNS disease or involvement, but they don't. I think partially it could be that we're using rituximab in our regimens, and a number of these patients are getting high-dose cytarabine that will penetrate into the CNS. However, if patients do have any neurological symptoms, they should have their spinal fluid evaluated not only by histology but also by more sensitive flow cytometry. But prophylaxis is not necessary in the typical patient except for the blastoid and perhaps the pleomorphic variant. Blastoid, absolutely, those patients should get CNS prophylaxis. Should all mantle cell lymphoma patients receive our maintenance? Not the younger. There's no data in the younger patients to date, but I say in the elderly patients that have other comorbidities that it is probably warranted, and that I typically do utilize Rituximab maintenance in my older patients and then save the other treatments for their second-line therapies after they progress after that. We should keep in mind that these tumors are radiation sensitive, and to palliate, say, bulky areas of disease, even if we can't cure the patient, we should consider giving involved field radiation therapy to those patients. And the role of stem cell transplant in mantle cell lymphoma patients we discussed, keeping in mind that typically auto transplant is utilized, but in those younger patients, especially if they have adequate HLA matched donors, an allogeneic stem cell transplant should be considered in a small number of patients that are healthy enough to undergo that have very refractory disease. At this point, I'd like to thank everybody for listening in to our overview of mantle cell lymphoma, as well as the two cases that were chosen for our discussion with respect to various treatment options. And I wish everybody a good day. Thank you.